I graduated 10 years ago in England. English is anyway not my mother language. Came back to Berlin, started 8 years ago my qualification for oral surgery, and that's when I put my first implant in. Became my implantology, became specialist in oral surgery like 4 years ago, and started my mobile implantology with the company Schütz ago. So this is the lecture overview. First we're going to compare conventional restorations with restorations on implants. Considerations which we have to do before we start an operation on patients. A little bit of anatomy. Preoperative and postoperative measures. Complications with implants. How to select a case and how to assess a case. Okay, let's compare conventional versus implants. With a fixed restoration first, we start with a fixed bridge. It used to be a gold standard. We have a 10-year survival rate of 85 and 90%, up to 90%, which is very successful. After years, we have about 70% survival rate. Unfortunately, with fixed implant restoration, 20-year, there is no study at the moment which shows after 20 years survival rate. But with fixed implant restoration, we have a similar success rate. The problem is with the fixed bridges, we have a irreversible damage to pulp due to preparation of the tooth in 10 to 15%, which is quite high. So every 10 tooths die after a few years. If we have a failure with fixed implant restoration, it's mostly due to superstructure. 95% of the implants heal. So the rest is due to the superstructure. With the removable restorations, we have overall, it doesn't matter if it's on teeth or implants, a worse long-time survival rate. So what we should aim is always a fixed, if possible. If not possible, obviously this is a good alternative, but if it's possible, do a fixed one. These figures is good tool to persuade a patient to do implants. I don't want to persuade them just because I want some money. I want to persuade them because I'm myself convinced of it. So, what are the advantages of implants? We have a higher survival rate, as we saw before. The comfort and the life quality is improved. And what we do is very important, is we prevent inactivity atrophy. If you don't have any teeth, the mandible or maxilla will melt. If we put an implant in, we can prevent it. The disadvantages of implants obviously are the costs, the risks of operation, infections, swelling, etc. And it's very time consuming. It can take up to 1.5 years. What is the patient asking for? Is it that implant or is it the crown? He's asking for the crown. He wants to have, when he comes in, he says, "Doctor, can you put me an implant in?" And what he really wants is this here, the superstructure. He doesn't care, or he doesn't know what an implant really is, where to put, how to put. All he wants to see at the end is this result. Well, overall consideration, when we start implantology, we have to look at the age of the patient, the patient expectation, what does he really expect, to meet his expectations. Okay, a little bit of anatomy. I hope you remember. Okay, what we have to look at is blood vessels, nerve innervation, of course, sinuses, and direction of resorption. In the lower jaw, what sort of structures do we have to be careful of? The mental nerve. Yeah. The sublingual and the submental artery. And one more structure. Bless you. This is the mental. The lingual nerve. Very important. I'll show you in a minute why. the lingual nerve. These are the four structures which we have to be very careful. Osteotomes, anyone knows, everybody knows what it is? Osteotomes, yeah? Excellent. You can do so many things with them. We have straight ones, and we have curved ones. So, what can we use the osteotome for? It can be used to expand and condense the bone. So condense in type 3 and type 4, and expand if you don't have enough width of the ridge. So what are the advantages if you use it? Minimal or no drilling. Minimal means that we have to use obviously the pilot drill first, and then we can anyway we preserve the bone. Okay, we don't remove the bone, and by preserving it we condense the bone, improves the bone density. We can reduce the undercuts in the jaw. Sometimes in the upper jaw we have an undercut, and if we take a burr we might perforate the undercut. With the osteotomes we can prevent it by expanding it in the undercut. I'll show you later how an undercut looks like. Okay, and we improve by all of this the bone implant contact. I'm going to show you now an example of using osteotomes for expanding the alveolar ridge. This is a patient for upper teeth missing, the central ones and the lateral ones. And, well, I'll show you. Sure. You can see, compared to this side, we have a little fall of the bone, too little bone here. When we open up, you can't really see the difference, but I prefer this kind of cut. Yeah, just a crystal cut. I don't like in the front teeth to relieve, because this leaves scar tissue. So it leaves scar tissue, and if he has a high lip line, it doesn't look very nice. Also what it does, so it gives you a recession if you do a relieving incision here. I use then a stand for the optimum position of the implant. Did my pilot burr through the stand. Expanded with the first one to make sure it expanded already. And then I took my stand away. I did the rest without the stand because I already have the position. So I enlarged, expanded the bone, I condensed the bone. Put my 4 implants in. This is the last one. We are nearly finished. Patient comes in. Quite a young lady. That's why we have to build it up as well here. But it was before she had a post and core crown, which was broken. Okay, leave it for healing. Open it up. You'll see no bone. You can't put an implant in here. What I did, the same thing again. Fortunately, I don't have the picture how I fixed it there. Sorry about it. But you can see, okay, much more bone than beforehand. Take out the screws, and then you can put in the implant. What you also can do, if you're not sure if this bone is already fixed to the recipient, take out one screw, burr into the bone, and see if it's moving. Put the screw back and wait a little bit longer. Okay. Of course I used implant. Suture back, and then you have an implant here. Okay. Little break then.